So yes, welcome everyone. Second session of the Momentum Accelerator. Now, the way we usually run these sessions is we'll usually do a quick introduction of all the attendees. So that's yourselves. So just a minute or so, introducing your name, your company, and what you do. One for the benefit of the speaker. But then also to remind each other of the services and innovations you have, and whether there's any further opportunity for collaboration. And the session usually is over 2 hours, but we usually have a break in between, and we try to make it a bit practical and try to get people to engage and get involved. It's not just about listening, so feel free to pose questions. Now, I have given some homework from last week in terms of the business case model canvas. Now, if you have done that, please feel free to send it on to me or set up a separate meeting so that we can kind of review it in depth, and then I can also get some input from colleagues of mine. These sessions usually start at around about 10 o'clock. We put them in the diary a bit earlier to get people to come in, get them settle down, and then give us the opportunity to speak to the speaker and make sure that his technical is working, and the sharing of slides, etc. Before we go into the introductions, has anyone got any questions at the moment? No? Okay, so I'm just going to start off with the names that I've got here. Andy, do you want to go first?
Yeah, and Andy Holland, yeah.
Yeah.
Sure. Yeah, I'm Andy Holland from Maywoods, and our innovation is our analytics solution that looks at the traffic going through electronic healthcare systems, and it surfaces insights in that data that helps organizations reduce their costs, improve quality of care, and we're kind of aimed at strategic decision maker level, people like CIOs, CCIOs in NHS organizations. So that gives you kind of a high level overview of our innovation.
Great, thanks a lot for that, Andy. Simon and Carlos, welcome. What we're just doing is quickly doing an introduction by each of the companies, just to mention your name and your company and what your innovation is for the benefit, one, of the speaker, but then also for colleagues to facilitate that collaboration. So Carlos, do you want to go next?
Yeah. I want to apologize. I'm struggling to connect on my computer, so I'm doing from my phone. But I'm trying to sort it out. As soon as I fix it, I will come to my computer, okay? Yes, so I'm Carlos. I'm co-founder of CCI Photonics. So we are developing an in vitro diagnostics near point of care device that is able to detect within 15 minutes the urinary tract infections, the bacteria causing the infection, and it will also provide antibiotic susceptibility testing on primary antibiotics. Nice to meet you.
Great, thanks. Ian Chung? Are you there, Ian?
Hi, Ian Chung from Maywoods. I think Andy gave the introduction to the company, but yeah.
Okay, great, thank you. Sab is on a call, so she can't actually speak at the moment, but she's just put in the chat. So I'll just quickly read it out. I'm Sab from Sisu Health. The Sisu platform combines a medical device with user-friendly digital interfaces to deliver personalized health insights. Each standard and mobile health kiosk performs essential health assessments such as blood pressure, BMI, CVD risk assessments, EGQ risk 3, diabetes risk, and lifestyle factors like stress, smoking, alcohol use, and physical activity levels. Utilizing cloud-based technology, each kiosk can provide a unique experience with immediate real-time feedback by the kiosk and integrated app. Health kiosks are placed in accessible locations to capture targeted and opportunistic health checks in places such as workplaces, community centres, libraries, shops, hospitals, etc. Users are presented with immediate results, recommendations, and the opportunity to self-refer to local services. A range of digital pathways can be obtained on the station by email and through a patient management tool to ensure users are directed to pre-existing local services and wherever possible to reduce the impact on primary care. Individuals with high risk can be triaged directly into GPs for immediate treatment. For those with a lower risk, an app and health portal can be accessed to review results and lifestyle recommendations to manage future risk through a range of content tools and gamification. Great, thanks a lot, Sav. Do you think I'd get a job at your place? Anyway, let's move on. So the next person that I'm got on my list here is Kevin.
I'm Kevin Moore. I'm a consultant physician, professor of hepatology based at UCL and Royal Free London. Our company, Salutari, have really 3 products, of which 2 of which are one is a digital phlebotomy platform that connects patients with their GP or hospital-based requests anywhere, so that they can have blood tests either in the community and pharmacies, as well as community diagnostic centres. The second product is one referral, which is a digital platform for discussion and multidisciplinary teams, which works well in secondary care, particularly where you've got regional referrals, but also we see a big opportunity within the neighbourhood care teams that are being developed across the UK. Thank you.
Thanks a lot, Kevin. Shane?
Hi, I'm Shane Koja, founder of Thriving AI. I'm a physiotherapist and a health tech individual. I'm building Thriving AI, which is an integrated care platform that basically helps monitor, communicate, and coordinate care. And at the base of it, there is a machine learning AI platform that collects all the data to provide deeper insights. So far, we've been able to demonstrate that older adults can use the technology, use it well, and it helps loneliness and isolation. It reduces stress on the caregiver and the caregiver burden by 50%. And it's saving care delivery 20 to 30 minutes. And we are looking at fitting into transition teams, step-down teams, community care, and neighborhood teams to help deliver a sustainable solution that is community-based, cheaper, and more desirable. Thanks.
Great, thanks a lot for that, Shane. Sean?
Yeah, hi, I'm Sean from NG Pod, and our innovation is basically a pH test that is based on a fiber optic sensor, and it's the only one that can test the end of a nasogastric tube at the end of the test at the end of the tube. It basically enables faster nutrition and medicine to a patient who currently requires a feeding tube, and it basically enables a reduction in x-rays and staff time and everything else. We've got a variety of different valuations, and we're currently in around 20 hospitals at the moment.
Some excellent adoption there. That's great, Sean. Thank you. Simon?
Hi, Simon Pickup. I'm head of health at Sweatcoin. Sweatcoin is a free-to-use pay-to-walk app. So we pay users around the globe. We've got nearly 200 million users to walk. So really much about motivating those that find it really difficult to motivate themselves and to move more. And my role is to turn that program into an educational and support program to reduce the burden of chronic conditions. And we co-created a program called the Prevention Decathlon, which has been recently evaluated by the Health Innovation Network in South London. And we have that available for cardiovascular disease and type 2 diabetes, and soon to have one available later this year in obesity.
Great. Have I missed anybody out? No. No hands are going up. Okay, great. Right, so I'm going to start off with the main part of this session today. That is about value proposition. And just one thing I want to mention is that last year, what we found is that we had a number of companies that were on the accelerator program, and many of them had been very successful in getting adoption within the healthcare system. However, what we found during the value proposition session is that many of them didn't feel as that their value proposition had been articulated in a strong enough way, and that from the session they were able to revise it and make it much stronger and more appealing to the customer. So whilst many of you think you'll have a strong proposition, and hopefully that will be the case, really try to take benefit from the session today in terms of enhancing that and strengthening it. So without further more from me, I'm going to hand over to Connor, who is from Coentry. Connor, do you want to introduce yourself and then commence the presentation? Thank you.
Yeah, sure. Great to meet everybody. Thanks for joining today's workshop. As Indy said, focusing on value proposition, but then also stakeholder engagement. It's quite interesting to see that obviously from kind of the introductions, you're all at different points in terms of that journey, and potentially like where you've scaled up with value proposition development and what that means to each of the companies. Moving kind of into the slides here, just kind of the session's aims today is kind of understand and sharpen your value proposition and align it to the challenges and opportunities that you've probably all faced within the NHS. Obviously, some have got greater adoption than others, so we're kind of dig into some of that. And the main aim for today's session is also to try and help and be interactive ultimately between yourselves. So there's a couple of elements where we'll kind of break off into kind of doing some work in some lean canvases and some stakeholder mapping and stuff like that, and then play that back to the group to kind of hopefully engage in some discussion around value proposition development, but then also the stakeholder mapping piece as well. And then ultimately with the stakeholder pieces, then aligning that to like the commercial approach you're potentially going to take, and how the NHS then makes decisions. Just wanted to cover off some the kind of learning objectives just to kind of keep us sharp in terms of what we're hoping to get from it. So ideally, some people, some companies on the call might have already spent a significant amount of time developing the value proposition. So it'd be really good if you have done that to kind of play that back when we come to the value proposition development piece. But hopefully it help you craft a strong stakeholder focused value proposition. Understand the NHS market engagement challenges and how you can kind of scale within the market. Map out your key stakeholders that you need to kind of be focusing on, so how the value proposition plays into that, and then hopefully align that into your sales cycle, making sure that kind of it's aligned to the NHS strategic priorities and funding elements that kind of shape the decision making within product adoption. Quick one on agenda. We've done introductions. There is a slide shortly around kind of the a little bit of a pitch from yourselves, because sometimes that's how we run these sessions, but we've already covered that, so we'll skip on through that. So proposition versus value proposition, and then some canvas work just to kind of keep us all running through. Challenges and opportunities as well, digging into that, so understanding what challenges you faced and the opportunities that are available to us, and then digging into a little bit more about applying the value proposition against the stakeholders that you're targeting as well. But please feel free to kind of ask questions, any thoughts, ideas that crop up as we're going through. It doesn't just have to be the Connor show in terms of running through everything, but we'll kind of kick straight off into the slides. So Coentry Health Tech, we are a company that supports digital health companies in terms of navigating NHS and private sector scale up. Our team works across strategy, adoption, market access and evidence generation, supporting it from everything from prospecting, BDM resource at a fractional level through to kind of strategic advisors supporting our customers as well, and helping develop the commercial models, that kind of thing. I think somebody popped their hand up just before, so I just want to pause set well, just to make sure that we've answered the question.
Connor, I was just going to ask that, you can obviously develop value propositions and map out your stakeholders, but because of the way the NHS is at the moment, you often have to kind of meander your way in through other ways. Will you cover some of that as well?
Ideally, yes, and some of the influences and, like you say, the kind of people that you need to have on side and kind of reference and kind of build that that kind of story up in terms of where you've come from and where you're aiming to get to. Yeah, for sure. But it'd be really good to get some insight from yourself as well in terms of that challenge, because it's not an easy thing taking people on the journey with you and kind of getting that support.
And when you're trying to kind of co-design with them, there just doesn't seem to be room for that. You're competing with much more established companies, it seems. You know, you have to have, the burden of proof is much higher now than it ever was in the past. So, you know, it's interesting to know how people are managing around that.
Yeah, and I cover that in some of the key barriers further on in the slides in terms of that kind of requirement for proof and evidence and the cost associated with delivering that and what's expected. And then also the kind of proof of concept pilot piece and the difference between a pilot deal and an enterprise deal, because there's, you know, a huge amount of difference in terms of the stakeholders you need to have engaged in the transition. I think people often find that once a pilot secured, the conversion of that into a commercial opportunity is going to be a little bit easier, but sometimes actually is quite a lot more difficult to kind of make that transition. So yeah, more than happy to kind of dig into some of that. Please feel free to chip in as we're going through. So kicking us off then, really, in terms of where we should all ideally start is kind of proposition versus value proposition. Ultimately, it's a key distinction. Proposition is typically what your product does, and value proposition aligns it to the specific person and a stakeholder. I'm sorry, I'm getting a bit of feedback from the mic. I don't know whether who it is, whether it's an echo or not, but that seems to be a bit better. Yeah, so proposition is typically what your product does, but then value proposition is what it means to a specific person or stakeholder. It's about impact, not just the features. When you were giving your kind of intros, it clearly shows there's a very different suite of applications that we're talking to, but also the kind of within each of the solutions, there's a raft of different value propositions you probably need to craft for each of the people that you're engaging with. So it's kind of key to make sure you've got that distinction between the value that each of those stakeholders is important to them ultimately. In terms of when building the value proposition, the key things there's three key questions ultimately that you want to kind of use to craft your value proposition. And that is, what problem do you solve, for who, and why does it matter to them, not just you? And I think one thing here that I've found, and I'd be really interested to get your thoughts, is the concept, because of the way that the system's set up and the funding channels, often the value proposition delivers value for one element of the system, but actually the payer of that solution would not necessarily receive the value. So there's a complicated mix of trying to judge exactly where the commercials fit into that piece around the value proposition as well, and how you can make sure that people are incentivized in the right way to kind of work with technology and your technology, if they're not necessarily paying for it and somebody else is feeling the benefit from it. So the case in point is primary care. There's a lot of work going in and innovations focused at primary care, but ultimately that's all about reducing secondary care admissions, but actually the benefit is felt at the secondary care level rather than the primary care. So it's just those kinds of things that you really need to think about when you're building your value proposition, that you've got that in mind when you're speaking to those key stakeholders. In terms of kind of before we jump into the next stage of this, which is kind of helping develop the value proposition, it'd be really good in terms of getting some feedback as to where you're at with regards to value proposition development, and just if anybody's got or done some work in terms of value proposition and mapping that out. It'd be really good if you could kind of run us through that before we kind of jump into the workshop and the activity. I don't know if anybody wants to jump in or. Anyone? No, it's not a problem if you've not, but if you want to jump in. So what we've done is I'll put it in the chat now. There's a link to a Canvas. Sorry.
I think Shane was going to say something.
Oh yeah, fire away.
I was going to say I'll throw myself to the lions, right? Yeah. So with Thriving AI, it helps community care, right? So delivery of care, transition of care, getting people back home sooner, so it empties beds. And it also helps save time for care delivery, which is under great stress. Now, for the healthcare worker, frontline worker, that's translated into time saving, more time to spend with the client, actually doing the caring and reducing the stress. But to a payer, that's more about, productivity, efficiency, saving time. And to a secondary care service, it's about the bed saving and sort of freeing up resources. So that's where it's so difficult. So very often you're having to kind of try present, if you like, right? Because you've got a group of people that you're speaking to, you've got the innovation expert, the CEO, the frontline staff, community care. And I think that's where you get into an issue, right? Because everyone's nodding and then they're all saying, you pay for it.
Yeah.
So it would be interesting to know how to segment those people, because very often they want to get all those people around the table, right? And you can't have 35 slides, you're down to like 10 or 12. So I think, it's not just the value proposition in my point of view, it's much more having that so succinct so that, there are 3 or 4 points and it hits all those people simultaneously. And that is very hard when you're doing an integrated solution. So that's my experience to date.
Yeah, definitely. And like you say, it's really difficult to trim that down. Like you say, when there's so many different elements and like kind of impacts for the different groups of stakeholders and things. And I think that's where sometimes the whole ICB level conversation comes in terms of, right, that will join all these people together and kind of get a strategy. But, ultimately then that adds another layer of complexity in there as well. So it's really key that I think you spend the time within each of the different stakeholder groups that you identify as to kind of build in that kind of them as champions within, and they can kind of sell the product from there. Carlos?
Yeah, I wanted to ask you at what point, in which life of the value proposition, having backed up data, let's say health economics or stuff like, should be included within the value proposition? Because I think, well, the thing that I've been facing is that we can make assumptions that we can save like a life in 15 minutes by quickly detecting the bacteria causing the infection. But if ultimately there is no like a economic savings for whomever is saving it, then where's the value proposition? Where should we, like, if we don't have a health economics, how should we build a value proposition? That's my question mostly. Yeah.
I think the value proposition would help you trying to get the health economic numbers as well. I think at this early stage it would be key to help try and drive like a pilot site or an engagement with an organization that helps you develop that element of the value proposition and where the health economics can factor in, and making it really clear that that's what you're looking for, and why should they kind of pilot the solution, and what that kind of what that could give them as an organization in terms of kind of publicity and exposure to new innovative technology, because a lot of these organizations that we're going to be talking about are really keen on kind of showcasing new innovations, but typically are held back from a budget perspective. But yeah, I definitely think it'd be worth that would be your ask, I think, and why would be around developing that pilot concept and health economics stuff, for sure.
Right, thank you.
Cool. So just moving on then into kind of a bit more of an interactive element of the session, I'm just going to share a quick link to the Canvas template that we've used previously into the chat. It means that you'll be able to kind of craft your own value proposition using this template, and then kind of save a copy of it and kind of come back to it each and every time. You might want to create multiple. But basically, the next part of the session is building out the value proposition. So if we can spend about 15, 20 minutes working through this canvas, and I'd suggest that you kind of focus on the problem, customer segments, unique value proposition, because that's another piece that we really need to, the market in terms of big players in certain spaces and competition that's there. It's really clear to it needs to be really clear within the value proposition as to why they should be using you rather than others, and what's different. So it's really key to make sure that you map that out as well. I don't know, has everybody managed to follow that link? Yep.
Yeah, I think we got it right on the email. We got some.
So I sent the business model canvas, which is very similar to this. But then there's this as the value proposition canvas, which utilizes the majority of the things in the business model canvas.
Yeah.
So the main thing here we're focusing on is like I said, the problem, the customer segments, unique value proposition, the solution, and the channels. And channels could be path to customers. I think you mentioned earlier, Shane, about the different channels that you need to engage. So whether that be a direct engagement with NHS trusts, organisations, PCNs, primary care networks, or whether there's a route via kind of health innovation network supporting and funding some of your work alongside NHS trusts, or whether there could be charity organisations or research organisations that you could access that would help get you into those organisations through kind of a secondary method. So if you were, for example, one of our clients is doing some work with a research charity, but it's actually centred in an NHS trust, so it's kind of targeting both those elements and building the evidence from there. So the next kind of phase of the workshop is just spending a little bit of time around outlining the problem and then the solution and the value proposition off the back of that, if we're able to. So we're at now 10:25. So if we come back together in, say, 15 minutes or so, once you've had time to kind of map that out. If there's any questions as we're going through, feel free to ask away. I'll just pop myself on mute and see how we're getting on. I think the main aim after we've spent a bit of time mapping this out is to then go back through and if everybody can kind of run through their what they've come up with in terms of problem, solution, and who we're targeting, that'd be really helpful. Are we getting on? Nearly there? A few more minutes and then we can dig into it a little bit deeper.
Yeah. How many we were? Which one? I mean, which ones we were supposed to?
Ideally, main focus is problem,
solution.
Yeah. Problem, solution, customer segments, and then unique value proposition for those, and any channels that you can identify as well would be really helpful.
Cool.
But we can kind of work through some of that as well. But it'd be good as well when we're kind of doing the playback to understand kind of what you've done in terms of engagement with your existing value proposition and how you've tried to engage stakeholders so far as well in that journey. It'd be really helpful.
Thank you.
Cool. Are we all pretty much there? Ish.
Fish, yeah.
Yeah, no problem. Yeah, and in this next session, we'll like hopefully play back some kind of thoughts that you've had in this space. But for those that have probably spent a bit more time in terms of value proposition development previously and engagements that where you've kind of got, you know, a little bit more scale and that kind of thing, it'd be really interesting, I think, for some of the other people on the call to understand like how you've utilized the value proposition that you've already got to kind of build messaging, get in front of the right people, and how it's gone to date, or whether you've actually spent much time in terms of value proposition to get to that point. Because part of what we do at Coentry is around how do we map that value proposition to key messaging, pitch decks, sales materials, marketing collaterals, events that we would attend to try and ensure that all of the right materials in place to ensure that when you are in front of the stakeholders or even getting in front of the stakeholders has the best chance of success. So it all stems from the value proposition ultimately. So yeah, I'm not sure who wants to go first. On my screen, I've got Phil Wright is top left on my screen, so we want to go around from Phil first.
Phil's one of my colleagues.
Oh, sorry. Yeah.
I'd be the worst.
Sorry, Phil.
Yeah.
Kevin is next to Phil. Sorry about that.
That's okay. So I'm just going to share my screen. I probably haven't done it properly, but I'm just going to share my screen with. Is that sharing?
Yep, I can see that. I'm just going to make you a little bit bigger.
So, the product that we've developed is a paperless digital phlebotomy solution that is cloud-based, which means it can be accessed anywhere, which ingests all of the GP and hospital-based requests, and which prints an analyzer-ready barcode label that can be applied to tubes when phlebotomists take your blood. What that means in practice is, since they scan the tubes as they take them, when the tubes arrive in the lab, they're ready to go straight onto the analyzer, because we do all the background work to make sure the barcodes can be read, so they can go straight onto the analyzer without any errors. And the problems that people face are, in this age of AI, patients still need a paper form. Many patients, not all of them, of course, need a paper form to have their blood taken. That's particularly true in the community diagnostic centres that are being developed, because they cannot connect to all the different EPR systems around the country, round in their area. We estimate there's about 50 to 100 million tubes, when they arrive in the labs, are relabeled manually because the labels that they used, or the handwritten labels, can't be read by the analyzer. So that leads to errors and delays. And so some labs are receiving like 15,000 tubes a day that they have to relabel, and they have to centrifuge them when they arrive just to keep them stable. And then the phlebotomists have to write the date and time on them manually, and then when they arrive in the lab, they have to be added manually in the computer. And then I've added a fourth problem, which is 5% of the tests that are done are just the same test done twice by mistake. And so our solution, as I've described at the outset, is cloud-based. It can be accessed anywhere. It prints analyzer-ready labels, and by scanning, it tells you who took the blood, when they took the blood, and that updates the lab order system. Shall I carry on? I don't want to.
Kevin, can I just jump in for a second, please, mate? Firstly, is probably need to zoom into your screen, because I don't know about other people, but I can't really see it.
Okay.
And I'm really interested to see your problem.
So hang on. Why can't I zoom in? Hang on. Oh, there you are.
Yeah. And if you move your cursor to the left of your screen.
How am I going to move my cursor? What's happening there?
Is there any horizontal bars and bars on the left?
Yeah, I think you hover over.
Okay, I think let's just do that. That'd be easy. I'm just doing it in my Word document. So
Yeah, no, that's fine. No, that's good. That's fine.
into Word.
It's a little bit more. I need to take my glasses off, I think.
Is that clear now?
Yeah. That's much better. Okay, so for me personally, and Connor, you can kind of jump in, right? One of the things is with the value proposition, you set out the problem, and then when you kind of explain the solution should tie into the problem and make it quite clear. So if I just take cloud-based solution that can be accessed anywhere, right? So is the problem that you can't access it anywhere at the moment? Do you understand what I'm trying to get at?
Yeah.
Yeah. So in a value proposition, that usually makes it easier to see the story, and then for your audience and your customer to be able to say, yeah, that is a problem that I'm encountering, and I can see how this solution will kind of overcome that problem.
Okay, got you.
Yeah. So ideally you'd have if there's 4 problem statements, you'd have 4 features of the solution that would link directly to each of those, and then can be tied into kind of a benefits ultimately, for the unique value proposition against each, linking them together.
Yeah, so the solution would be one cloud-based solution that replaces the paper form because it can be accessed anywhere. 2, it prints and analyzes a ready label so that no tubes need to be relabeled. 3, by scanning the tubes at the time of phlebotomy, it automatically updates the lab system with the date and time it was collected. And then finally, it can identify electronically duplicate tests and just print one label. So it's only done once.
Yeah, and then the value element then ties to each one of those in terms of what that drives as a value to the system.
Yeah, so if you go to...
Indy, sorry, did you something to add?
Yeah, I just also wanted to add, in terms of go back to the problem there, right? I would always kind of pose the question, so what? Like you've said here in 1, tubes relabeled leading to errors and delays. So is that 1 error per day? Is that 1,000 errors? What does that then kind of like quantify in terms of, is it like a whole time equivalent is having to spend a day relabeling? So it kind of brings a bit more context to the problem, really.
Yeah. So for typically a lab, they may employ 20 people just to do this job.
And so when you say like 20 people, that is quite significant.
Yeah, of course. Massive.
Yeah. Compared to 1 or 2 tubes that need relabeling. So it kind of gives an kind of indication of the extent of the problem.
And the errors are up to 0.6% in the audits that we've done. So you can work that out. 0.6% of 100 million is 600,000 errors, wrong results.
So that for me, that would go somewhere in your problem statement, that there's 600,000 errors occurring.
Yeah. Okay.
Yep. That's really good though, like you say, in terms of like mapping out it's just the train of that kind of value that is passed through. And then ultimately, when it comes to the stakeholder mapping piece, identifying the stakeholders that each one of those kind of like value streams and where it kind of ties into them and what it means to them is kind of really helpful as well.
And I won't go because other people have got to go, but for the unique value, these have got to tie in with these 4 because I've kind of just listed them randomly, but they've all got to tie in as well, I assume.
Yeah, ultimately. And then, there's other factors. So like, for example, there's certain NHS like policy and kind of key NHS priorities that if you can kind of round them up and link them into the NHS priorities that people are that are very widely known, in terms of the NHS long-term plan and things like that are being pulled out, then it kind of all, in terms of that influences and all of the different stakeholders, it kind of gets everybody listening a little bit better.
Got you.
Who else wants to go next? I'm just looking at my screen.
It's Andy Holland here. Can I go next?
Yeah, of course. Jump in.
Okay. And like I said, I spoke to my colleague Ian Chung, and we've had a bit of a go at this. I'll share my screen.
Yeah.
You know, we're in a sort of really the early stages really of our product development compared to some of the other, you know, organizations that are on the program with us. But do you want me to try and zoom in on this a bit? Or maybe go to try focus mode. Does that?
You might be able to just zoom on your window, I think. If you do like a Control or a Command F or something like that, it should allow you to zoom in, and then you'll be able to, yeah, if you can.
Is that any good?
I can see that, okay, yeah.
You see the bit on the right-hand side, yeah?
Yeah.
So where do you want me to start? The problem?
Yeah, ultimately, and then we can follow that through. But like Indy said before, I'm conscious that potentially some other people might have not done the same thing, like you say, where it's the problem and how each of those then links through. But we can kind of dig into that a little bit more if we need to outside the call. But yeah, sure. It's good to get a feel for where you're at.
Well, I mean, we don't have a sort of you know, a direct problem that we're trying to solve here. You know, like, you know, splints for a patient's broken leg or something. And really, we're trying to highlight a problem that maybe people sort of, or an opportunity, more of an opportunity that people don't know about. And we reckon that healthcare organizations are generating this vast footprint of data when within their electronic healthcare record systems. It's really around how records are created and who by and who's actually viewing them. So we think there's an opportunity to analyze that. And our solution is, and this isn't, although this is a product that's sort of in development for us, it is built on the back of our, you know, previous products that are, you know, actually out there in the market. But it's a different approach. And we want to analyze that data footprint and transform that into a dashboard of, you know, actionable insights. So we've got a system that, you know, back-end system that analyzes this, and then we try and link the insights in with, you know, clinical best practice and published research, and then, you know, put the whole thing together and show that in a dashboard. So we think that, so that gives our value proposition is about turning millions of daily NHS electronic record interactions into actionable intelligence. So we combine that with some AI-driven analysis, clinical context, published research, and we deliver evidence-backed recommendations through a practical dashboard.
And so, just on that end point, just in terms of the evidence-backed recommendations, is that like clinical recommendations for patient care, or is that kind of population recommendations, like and trends analysis and things like that? Just
okay. So we try and tie that into high-level values of improving the quality of care, cost saving and efficiencies, and also targeting the consequences and causes of health inequalities.
Okay, that makes sense. Yeah. Indy, I think you were going to jump in, but I've got some thoughts too as well.
Yeah, and all I was going to really say is, you know, the NHS is huge. You know, health records has a huge amount of information on there.
Yeah.
Right? And I think for adoption purposes, identifying a specific used case would probably help in getting adoption, because you know, this will, even though you be able to do what you're suggesting, right, for clinicians to see the benefit, it has to be much closer to home.
I think there's and I don't know whether this will help, I hope it will, but one client that we've worked with previously has not done something similar to you, but had this same kind of problem, like looking at analysing data and and it was they were trying to figure out kind of how they kind of create the use case. But one thing to think about might be the long-term conditions strategies and things like that. And so tying your problem into there's all of this activity and kind of interaction across an EPR that is all around managing long-term conditions and how long-term conditions are managed, because there's a lot in terms of policy and NHS long-term plan kind of material where there's a lot of focus within organisations around long-term conditions and the management of those chronic conditions. And if we can kind of tie in the platform that you're building to kind of how that can then identify and flag kind of trends and issues in terms of how long-term conditions are being managed, and then the impact on patient care and potentially readmissions and things like that, that could be the way that value chain flows. I think it's really key, like Indy says, to pick an area that you can really demonstrate exactly what each of those statements is saying. And I think that the problem statement could be driven from some of the materials at like NHS, like at a policy level, in terms of what the challenges are around some of these systems and how how much data there is available, but it's underutilized and undertapped.
Yeah, I get that. You're talking about the sort of practical sort of examples that we can pull out.
Yeah, because I think that's what tends to happen within the NHS. You kind of have to, and with experience, kind of give them. It's giving them. A lot of people can kind of go there and have these meetings and explain, oh, we could do all this stuff, but then people tend to glaze over, and it tends to be a little bit like, oh, well, you need to really drill into a specific problem that they have and how you can fix it, because otherwise it becomes a little bit overwhelming, that the art of the possible ultimately. So you need to really make it specific. It kind of feels like a little bit like you're doing yourself an injustice, because you can do so much, but actually it allows the process to speed up a lot more, because you can kind of build a business case off the back of it.
Yeah.
A lot more specifically.
Okay. Yeah. I get that.
Mind if I just chip in as well? I think.
Sorry, sure. Ian, can I just say just one thing before I forget? Indy, I just went over to the customer segments thing, and I think when you talk about the sort of clinical benefit, I think it's kind of difficult for us, because we're kind of aiming our target audience at, like, strategic and executive decision makers, really, like the CIO, more sort of chief clinical information officer, chief nursing information officer. So it sometimes seems that it's a bit, it's not exactly like clinical, the benefit. It's more like for planning and assurance, the tool that we're offering.
So it comes back, and then this whole intention of this session is to establish what the problem statement is. So what is the problem they are having that you are trying to fulfill? Because having additional information may be beneficial to them and maybe good to have, but have they got the money to pay for it?
Yeah. Okay.
And the way that NHS works is really understanding the value proposition and the benefits and impact it can have, and building the evidence base. Unfortunately, there's lots of innovation and technology that's out there that would benefit clinicians, would benefit patients, would be good to have, but because of the limited resources, it's just never going to be seen. It's never going to be adopted. And the whole idea of today is really to kind of encourage us to really think about that problem statement and then link that into your innovation.
Okay. Right. Well, I think we've got some work to do. Ian, sorry to cut you off there. Do you want to come back in?
Yeah, it was just a bit of feedback in response to what Indy was saying, and obviously about the use cases. It's really difficult for us to articulate, I think, on this very high level canvas. Appreciate what he's trying to do, but what's positive is when you're saying use case practical examples, we do have them. So what we did was we sort of talked this through ourselves and saying, look, you can overwhelm that audience by saying you've got millions of transactions and all these benefits, but really, like I said, their eyes sort of glaze over, and we have sort of tested this a little bit and with a proper NHS audience. And when we did show the example use cases, so we went to a specific example down to a clinical example where someone is sat down, and it was to do with like cancer pathology tests and how you would apply our system in that example. And I'm just a bit of feedback for the group, just to back up what you say. That then resonated with that audience, and rather than sort of getting that glazed look of, it sounds great, your idea, but where do we start? It was exactly like, that. we can see the practical implementation of your product. And I was just a feedback to say, yeah, we agree with that completely, and that is some work that we're undertaking, is to say, look, we do need to start somewhere. We've got all these great ideas, but we found probably about 10 practical ones where you could sit with that clinician in that area and they would understand, they could see that pathway, they could see that use case, and they could see where, if they had access to our insights, where those benefits are actually going to, deliver for them. And it was just to say, completely agree. Maybe a bit more work on this canvas, but we are doing that as well, looking at those real practical use cases.
Yeah. Guys, what I suggest, right, is let's pick this up outside of this meeting a little bit more, and set up a separate meeting with me. I've got some ideas in my mind that I could probably talk to you about.
Yeah,
thanks, Cindy.
That's great, and that's kind of where we got to really with this, Canvasizer.
Yeah, thank you. No, that's really good, and thanks for the insight. I think it's also key when that case study development, it's around making sure that it's repeatable as well. So like you say, if you found certain pathways or areas that you think actually this area or pathway is present in multiple organizations and the benefit can be felt across, then it makes a solution scalable then, and you don't have to redesign or reinvent the wheel every time you speak to a new organization. So it makes complete sense that you're able to do that.
Yeah, that's good.
Conscious of time a little bit, Indy, I know that you were. Do you want to jump in?
Just a quick one. Do we just want to have a quick comfort break?
Yeah, sure, not a problem. Do we want to take till 2 minutes past till 7?
5 minutes. Yeah.
7, and then we can come back.
Okay.
Yeah.
Cool. No worries. Well, we'll be back online in 5 minutes.
Cheers.
Great, thank you.
I've filled in my canvas and I'm not sure it should look so messy, to be honest. So
at least there's plenty to put in there. That's the main thing.
And yeah. Well, I'm relatively new to our organisation, so I was kind of brought in to have a look at what I thought about these things. So I've got a lot of notes in a lot of places about, I'm only 3 months in, and this has given me the opportunity to kind of like put that in one place. So at least that's really something. Yeah. So
100%.
Be good to get some feedback.
I try to just do the AI version. Does it work out right or not? Have you ever tried it?
On this template?
Yeah.
I've not. No, I've only used a template where we've kind of used it in this workshop setting. It'd be pretty cool if it does give you all the answers.
Oh, I just wonder. It'd be interesting to see it.
Yeah. When I accidentally went down that route, it only gave you a little bit in each section before it asked you to unblur. And they were right, but they were quite generic, if you know what I mean.
Yeah.
So yeah.
I'm just conscious of time a little bit, but I think it's worth us just having a quick round the table with everybody else. I don't want everybody to not end up having to go. Collis, you mentioned about going next. And then so if we can spend like a minute or so on each, and then if we need to pick it up after the session, I'm happy to kind of catch up with everybody separately. And I think, Indy, you mentioned the same as well, to kind of touch base with everybody afterwards if we want to spend a bit more time on this.
Yeah, so, just want to jump in there. The intention of today really is to make an introduction. Right, some of you may come out with something that is 80-90% there in terms of value proposition by the end of today's session, a lot of you probably won't do. And also, I suppose the other thing to do, you may have more than one value proposition. You may have a few for different customers, and then you're always revising it as well. So, don't think that we're not there to kind of assist. And one of the things that part of our program we offer is that additional one-to-one support with the specific pieces of work that we're doing. So, yeah, as Connor said, we can pick this up outside on an individual basis to really go through it and thrash it out and get it right.
So, Indy, would you suggest that we have a go, to fill out the whole thing, maybe for 3 customer segments, right? And then share that with you and book a time to actually break through each piece of it?
Yeah, something like that would work. Obviously, you guys need to try to do some of the groundwork, but then we can kind of review it and provide some feedback.
Yeah.
Sure. So just where we're at time-wise, Carlos, do you want to jump in? But if we can keep it to, because I want to get round everybody just to kind of see where you guys got up to. And obviously some people are a little bit further on in terms of the kind of deployment into the NHS and things like that. So it might be a little bit different there. So yeah, if we want to jump in first, Carlos, a couple of minutes, and then everybody else, and then
it's gonna be I'll try to be very brief. So as I said, it's gonna be. I wanted to go third because it's we are in a very, very peculiar space where we are starting to dig into the USA as well. I don't know how to do it. So I have put also the what's going on? The UK and the USA together. So it's very, very annoying. I don't like this page. Sorry, it's very not friendly. I used to work with Mural, and Mural is more friendly than this.
Yes, it is. Yeah.
So okay, so the problem is that there's like a long waiting times overall for in the UK to wait for a prescription, and then and in the UK normally they are prescribed the best guess. They just assume by questions and etc. So what's normally for UTIs it's like referring to in the best guess. If not, if it's recurrence, then they will assume that it's either amoxicillin or trimethoprim, depending on the situation of the patient. But in the US, this works different because you have to do a lot of tests before prescribing. So they have to wait first, etc. And then in the US, our application will be much different. So it will be just for identification of a species first. So that's a game changer for us because it's gonna be different as it works differently. So the solution, it's a device, a point of care device that within 15 minutes can tell you the bacteria causing the infection, but also the antibiotic susceptibility. So this will give in the UK an informed prescription tool, better patient outcomes, antibiotics stewardship, and easy to use minimal training device. So that's where we are aiming for. So then we believe that we are like very unique because we can detect from bioflux directly, but also from culture, and tells you in a very, very short amount of time what antibiotic susceptibility the bacteria causing infection has. And like currently there's no test that can or like there's tests like blood sugar flow tests or like some tests like provide you this, but like in a very reduced range. In the UK, the customer segments are mainly the end users will be GP practices, clinics, and who will be using it, according to the interviews that I have done, will be GPs, healthcare assistants, nurses. But ultimately, who will acquire it and who will need to convince them, that's why I was mentioning the health economics, is the PCNs or the ICBs. So, and in the USA, it's just straightforward, like to clinics and labs performing the species, like or like if it's a private clinic, they will do it immediately. So, and it takes me to the channels. In the UK, is, as I said, through ICBs or PCNs. or like for example, if the Health Innovation Northwest has like some connections, like that's how we can start dialoguing, like start the dialogue. But in the USA, it's like through end buyers, decision makers, like clinics, lab owners, or through consultants, because last week I spoke with a few consultants that facilitate this connection. So that's very different how it works. And we come to the value proposition, and probably you already read it, which is a biofluid or culture, easy to use 15-minute test compared to current 72 hours waiting that provides ID and AST information to make informed supported prescription. And for the USA, it will be like a biofluid or cultural easy to use 15-minute test that provides ID detection species, enhancing the antibiotic susceptibility test workflows. So with this, we will help to their current dynamics because it's in the law that they have to do an antibiotic susceptibility test regardless of that, or according to what they told me. So, but we will be helping to enhance just the detection of a species. So yeah, I don't know. Yeah, open to suggestions. Let me know.
Yeah. Okay. I think from the problem, you probably need to build out the problem to be more like outline to kind of some key challenges at PCN level because of the way that it's funded as well. So in terms of like the issues, so if patients are being prescribed the wrong prescription and then the problem's persisted, and then that kind of enhances to something where they might need to, have a secondary care acute instance. It's kind of following what we said earlier, where it's identifying that problem, what impact does that have on the system, and what does that mean for patient care, but does that mean more workload for GPs that they're having to see more people repeatedly? How do you take that kind of additional capacity? It's those kind of things that I think you'd need to probably just enhance that problem statement with, as well as some other stuff. But Indy, you got
just so the one question I've always got for you guys, right, is in the problem statement, think about the who. Who's this for? Right. Really think about your customer. So following on from what kind of say. And then the other one is so what? Right. So what does that mean? Yeah. So what's that? The impact of that? What's the result of that? This long waiting times to know bacterial ID and AST up to 70. So what? Why is that a problem? It could be that that's not an issue. Why do we need to know it sooner? So it's really thinking about that.
Yeah. Okay.
Do we want to just cover Indy? I'm just conscious of time. Is it worth us just doing everybody else just quickly, or are we? Is it worth us taking it offline and doing it separately?
So I'm conscious of time. So what I would suggest, right, is if there's anybody that is eager to share with the group and go through here now, right, we can do that. Otherwise, we can pick it up outside. Because I don't want to lose time in terms of some of the other stuff that you've got to present.
So I'm not sure what everybody's thoughts are. Are we happy to kind of crack on?
Yeah, happy to crack on.
Cool. Yeah. Okay.
So some of it, I can see it. Some of you thinking, phew.
I'm happy to share, but I mean also in terms of the time wise, happy to crack on.
Yeah, mine is quite expansive, so I don't think I could do it in a minute. So
okay, let's crack on, and guys, please send some time availabilities, and we'll catch up outside.
Yeah, I'm just gonna get my screen ready again. I made you all bigger so I could see what you were sharing. Cool. Okay, so let's just where are we? Here we go. Can you see my screen all right now? Yeah. See some nods. Cool. Okay, so this would be really good for the people that probably haven't answered in terms of the value proposition. The next kind of thing we're going to move into is around like the challenges and opportunities within the market and what people have been kind of facing so far, and then how we can then kind of unpick the value proposition, transition into the stakeholders, how you can engage the stakeholders. So I've just put some kind of questions on screen now around challenges and opportunities that you've had within the NHS and kind of your kind of campaigns and work to date. Simon, Sean, I don't know if you want to kind of start us off, but in terms of like your like kind of like I say, engagements today, where have you encountered the most friction? You know, have you had interest from clinicians but struggled to progress commercially? Like what's been the hardest thing to navigate really so far, or has it just all been a bit of a minefield? But it'd be good for the people that have not kind of shared yet to kind of start us off. I think Sean, you've come off mute if you want to jump in.
Yeah, I can. Yeah, so I think one of the biggest challenges we still face, even being in 20 hospitals now, is every single hospital want to start again as if you're a new, what we are new technology, but an unproven one. We have a clinical trial published in the BMJ. We have about 30 evaluations data that all prove our statistics, and we also have now, I think we've sold to date 55,000 of the sensors that we do and 350 pods. We are mainly, I think, in terms of the Northwest in particular, I think we represent nearly 33% of the beds in the Northwest, and that's going up. But we still have this issue that everybody wants to do evaluations. They all want to do, and then, which isn't an issue. But what then ends up happening, it's that from the evaluation stage to actually let's say a sale or implementation, it just gets put into committees. People jump out the woodwork, say, oh, we need to be involved in this and we need to do this bit, and let's do another evaluation on our side. And we even have it to a extent where we'll have a hospital in a particular ward, normally stroke, using it, and say gastro or respiratory or something else or ICU or whatever, they want to do their own evaluation, even though it's in the ward down the corridor, and they actually have their colleagues using it. And this is the real frustration that we've had in the past. So our original sort of target was to adopt full sites of hospitals, which we have done in Doncaster and Tameside, but to get the full usage, to get the full benefit for the hospital, that they can save 70% of x-rays for placing a tube, to make sure confirmation, all this sort of stuff, to get the real benefit, i.e. the value for them. But honestly, it just gets lost in committee month after month after month. Salford was a prime example. I think that took 3 years going through committees, and this particular problem, I didn't share the canvas, but this particular problem is a never event, i.e. it's never in the NHS. It's something they should be looking at, because a misplacement of a feeding tube can either seriously harm or kill people, which it does. So even with that, we've had ones where hospitals come on and they have had a never event. It's all frantic. It's all, oh yeah, we've got to get this in. It's great. And then time goes by, committees get involved, and it dwindles, even though they've had a never event. And this is, one of the main challenges that we have, and we are working actually with HIN Oxford and doing a full kind of stroke pilot, and we're trying to move that into a national pilot for stroke, because we are now saying, we are being more tough now and saying, look, we're not doing an evaluation, we're going to do a pilot. This is what we do, and we basically expect them to continue to use it after the pilot, and everything needs to be signed off before we do the pilot, because we have had hospitals where we've trained the staff 5 or 6 times, which is a massive waste of NHS resource, never mind our cost. But and then you'll have a new consultant come in, starts all over again. Oh, I've not seen this, I want to get involved. So that's basically some of the challenges that we have, and we are now trying to get this pilot scheme up and running, and working further up the chain in terms of the HINs, to try and resolve this overall new technology fear. And then the other challenge is, once it's in, it's the human behavior change. That's the biggest thing. Nurses and things if they suddenly become unsure, they revert back to the old ways, or they just don't believe it. We've had cases where they're getting the green result, the right result to say that they can feed, and they still send to X-ray, because again, it's the change in the trust in the technology. So that's some of the challenges we've had, even though we have broken through into a number of Northwest hospitals and now Midland hospitals, and we've actually got 3 starting in Ireland and 1 in Scotland. So we have so much data that backs up our claims, and even that we're actually also doing that. We are being chosen for a value-based procurement project by the NHS supply chain, and again, they're trying to prove the figures by working with hospitals, and the hospitals they're just not providing the data. They don't know where to get the data from, X-ray data, tube data, all this sort of stuff. So it just goes in circles.
Yeah, I feel your pain. It's changing. The typical tack tends to be land and expand, like you say, in an organisation, get one pilot site and going from there. But then it's the reframing, isn't it? Then away from being the kind of, I suppose, it's a pilot's new concept as this is actually proven technology and you can run at pace with that. And I think like one of the things I was going to say was how you can try and transition to that influencer kind of national bodies, stakeholders that kind of support you at a more like regional and national level. But obviously you've done quite an extensive piece of work to try and engage that, because I think that stops or helps prevent that need for local evidence each and every time and running the pilots, because like you say, it's that conversion from a pilot into a commercial like agreement as well that you kind of end up having to sometimes jump through the same hoops. Obviously template documentation, having all the materials ready and available in order to kind of go through those committee meetings and things. You're probably well versed in pulling all together all the content that you need for those, but even that is kind of labor intensive and resource heavy. So but yeah, I think the right tact in terms of trying to get that bit higher again in terms of even if it's ICB level conversations and stuff like that. Once you've got the use cases in a few organizations within an area, at least you've got that footprint within a region that you can kind of leverage in terms of conversations at a higher level. Shane,
there was a question for Sean, actually. There are 2 questions. One is, how far off your business plan have all these sort of delayed conversations taken to get to a contract or somewhere where you can actually sort of see the traction, the true traction, not the pilot traction? And do you have any comment about how smaller hospitals, perhaps in the Midlands and the North, are like to work with as compared to the large sort of London, big city centre kind of hospitals?
So just that bit. So we have getting stuck in large teaching hospitals, especially so Salford, for example, is part of the NCA, which is a bigger group, Northern Care Alliance, which is Salford, Bury, Oldham, and Rochdale. When you get involved in that honestly, that engagement started 3 years ago. Salford wanted to roll out, it then went into NCA, and they wanted to do all the hospitals. Now, obviously, that's 3 years, and now the positive angle there is that they're all now rolling out. But that's 3 years. That's 3 years time. So I think the district hospitals, the smaller bed hospitals, are far easier to get up and going. They still take a bit of time because of valuations and certain committees, but we've gone down a slightly better, what Connor sort of said in terms of land and expand. We found our best element is fire stroke, because one, it's the smaller wards, it's easier, they have a high use of NG tubes for stroke patients and things. So, and because they use it all the time, the change management's a lot quicker, because they're not having these big pauses like general wards. They might only have a NG tube on a general ward every 4 months, so forgetting how to use it and all this sort of stuff. So I think the smaller hospitals have an easier path, but it's still harder. And where we are at the moment, we're sort of in that world of land and expand, because even then it's a challenge. But if you find the dominant thing, a dominant person within it, they can roll forward and push through procurement quite easily. That's, the next stumbling block is procurement. How are we going to show these savings? How are we going to show these efficiencies and all these sort of things? How are we going to track it? You get into my world of accountants, just trying to look at numbers and all this sort of stuff. So the smaller hospitals are definitely slightly easier, but my experience so far is actually specific disciplines within hospitals, smaller hospitals, and you get much more quicker pilots and transactions because they are more engaged and they are the ones with the real problem that they're trying to solve. And you almost go in by stealth. We had a hospital, Worcester, who said, as soon as you go to the full hospital, there's committees, there's protocol changes, every training, and it becomes quite daunting for them. Whereas they say, this is procurement, and they're saying, if you start off with stroke, you kind of go in by stealth and expand through stealth. So that's our experience today. Teaching hospitals are just huge. Committees are huge. And the delays, and you only would need one member not to turn up to committee and it gets delayed another 4 months.
Thanks a lot, Sean. That's really helpful.
Kevin, no, you had your hand up.
Yeah, I'm one of these people that's used to sit on these committees, and it's a nightmare. It's a complete nightmare. And not only do you get rolled over, but even when you write to people, most of the time they never respond. And then if you do get a response, it's usually an automatic response, say that they're on holiday for the next 4 weeks.
Yeah.
And it's so disheartening. We have the same problem with selling our product, even though it's been very successful. Other people all want to do their pilots to make sure that it fulfills their needs, and it all creates difficulties because if they do a pilot, they're never really fully bought in, and quite often they want to do it for nothing. So they've got no commitment, and then there's no commitment then to do the DPIA or all the other bits of paper that need to be approved. They all get pushed down, so it's very long. The only thing I would say is that, if you can try and do some as maybe an open audit or a trial that you can publish, because people really value published data almost above and beyond any personal experience.
Yeah, we have a full clinical trial in the BMJ. It's a full. It's funny actually. I didn't realise North Middlesex was part of the Royal Free Group, and Costas there. I don't know if have heard of Costas. He's a stroke dietitian. He's just done a publication, and I think they came second or something in the Innovation Award. For the NG pod trial, and they've done a real nice poster, and they're looking to publish it in the US actually as well. So we have so much data and publicized work and evaluation publication. Leicester have done an amazing one about how it's not even about how the delays of ordering an X-ray. The worst case, just getting a confirmation that they're going to do the X-ray can take 23 hours, and that's 23 hours of a person who's not been able to feed or have any medication until they confirm that tube is there. Our result, we get a result within 5 minutes. And we even go down the route of going, look, you can continue to aspirate, i.e. try and get stomach fluid out, but a simple thing would be is if you cannot get aspirate, instead of sending them to X-ray, do an NG pod test at £6 instead of 150 quid for an X-ray or whatever it may be, and it's still this thing they have because
it's still not clear to me, just on that, just as a technical point, is if patients are on proton pump inhibitors. Although you can measure the gastric pH, I assume it'll be too high for placement, won't it?
No, we still get it. So our trial, we had a lot of ICU and ITU patients, and we still got. I think it was 75%. We had confirmation of the tube, and again we've got the clinical data. that I can send to you if you want to have a look, because I know that was your remit as you mentioned.
Well, I wrote the ANG policy for the Royal Free, so I mean, I'm happy to try and help at this end, just as an offer. But I mean, it's
no, any help.
I used to be in charge of it, but I mean, I gave up being head of nutrition years ago. But
I think the other thing as well is angles of nutrition nurses is that they fear that we're trying to take their jobs because of that we're making it easier. We have had some comments like that in the past.
No, that's nonsense. No, I can't see anyone would think that, to be honest. This is just a different way of working. pH papers are good, X-rays take too long, and this is an alternative. That's all.
Yeah. So, that's where we are at the moment.
Cool. Anybody else want to jump in, but or should we move on a little bit? But Simon, do you want to?
I was going to say very quickly, just to echo the comments that were made. Very similar situation where you gain initial interest, and it then goes to sort of a committee level, and you get some skepticism, which is expected, and then it kind of gets lost in terms of the originality of trying to provide the service. And then obviously budget gets in the way, and then maybe no one knows their role because redundancies are put in the way. And then obviously time goes by, and then momentum shifts away from providing the solution from the outset. The other bit mentioned about trial, each of our programs have been evaluated. When we've talked about getting them evaluated, so I'm in discussion at the moment, and the cost of that evaluation is huge, and far outweighs actually the cost of providing the solution. So in a lot of cases, when trying to provide the pilot, a lot of the ICBs are trying to get it within the 10,000 sort of, I suppose, procurement eye, and therefore there isn't an opportunity to get it clinically evaluated under that level.
Yeah, definitely. And like you say, it prevents you then, doesn't it? And I think that Kevin, you mentioned before around or it might be somebody else mentioned about the whole concept of free of charge, and then everybody's not as committed if there's no money there behind it that they're putting their name to. So it's always, historically, a good few years ago, it was always right. Let's do a 6-month free of proof of concept trial, free of charge. After that, you'll be able to convert this into a commercial deal, and it'll all be hunky dory. But it doesn't feel like that works the same. It just kind of ends up being that you are giving something free, and the onus is not there the same. So completely echo that sentiment as well. You've got to be really cautious. I think getting a commitment for some spend, even if it's £5,000-10,000, there's some level of commitment to going through the hoops to get, to actually work with a solution. And I think that's really key to kind of test that buy-in signal.
And I think it goes back to when we all met, that passport can't come soon enough. Because if we've all passed that first hurdle, then that cuts a lot of the pain away, and then it's just about trying to unlock local spend. But if there's a want to move to prevention, then there should be some investment nationally to each regional level to be able to unlock that spend. And then I suppose it's then a queuing system of how good is your opportunity versus arrival.
Yeah, definitely. Cool. So just going to move on. So we've done a bit of brainstorming there, but obviously we talked about, and you're all aware of what the UK has to offer in terms of the spend within this space, and we've done a bit of value mapping in terms of understanding where the value proposition lands and who's involved. But this is just to try and kind of articulate the engagement opportunities and the various different angles that you can kind of tap into in order to kind of get to that point where you kind of get adoption at scale. Sure, you mentioned about kind of bringing in that more regional level, higher influence stakeholders, and kind of having a finger on the pulse of all the different organisations that could have an impact to kind of support the technology. I think is really key. One thing that I would say is the land and expand strategy is always great to get that initial adoption and traction, but not long after that. It's really key to kind of start down that top-down approach as well, rather than just doing a top-down approach and targeting ICBs. When you look at the numbers of ICBs, which we know the structure of that is changing over the coming months and things like that. But your kind of footprint in terms of stakeholders you have to target is obviously a lot smaller. So I think you have to kind of develop a two-pronged approach in terms of bottom up and top down in terms of the stakeholder engagement. All these kind of outlines and things are going to be shared after the workshop today, so you can kind of get access to these, and I'm happy to run through anything in more details. But obviously the ICB ICS landscape is going to change. PCN networks are huge amounts of and numbers of those. Same with then the practices that sit within mental health trusts, NHS Foundation Trust, teaching hospitals, all that kind of stuff that sits within all of the networks. Is a myriad of different stakeholders, all to kind of target and build out value propositions for, which is I think where we're kind of leading into. Obviously, they've got the influencers piece as well around the health innovation networks to support new innovations into the organisations within their regions, but obviously develop the value proposition, hence today's meeting, as well, to kind of run through kind of how best to get that adoption as well. So yeah, trying that kind of two-pronged approach is really helpful. Just in terms of market access barriers, we've talked about some of this on that kind of little segment we just did, but in terms of stumbling blocks, governance, procurement, funding windows, unclear evidence, all that kind of stuff has to be kind of thought about. When we kind of come onto the stakeholders, I tend to group the stakeholders into different buckets. So you've got clinical, operational, the finance side of things, IT, and then governance as well, and having kind of each of the stakeholders in those like buckets, and then what it means to them. And also I would suggest something we've just recently developed is having a backup contact against each one of your contacts, so you've not just got one single point of failure. So developing a champion, which we'll kind of go on to, is really good kind of way to make sure you kind of get adoption, and you kind of have a point of contact that's really on board and championing your solution within an organization. But something we built in now is having a backup through that process as well, because I think we've all been aware of how many times people change roles. You can't get in contact with someone. I think, Kevin, you mentioned you get the responses saying I'm on leave for a month and all that kind of stuff, and then all of a sudden you're stalled if you've got one single point of failure. So it's really critical to have a secondary contact in each of the different areas to make sure that you can kind of still get updates and chase things through and still make progress with the work you're doing. This kind of section now kind of helps you to map your stakeholders. So we talked about a few more of the people that you'd be engaging with, and trying to kind of map out the influencer matrix. So those that are in the top right, high influence, high interest, are the people that you want to be nurturing the most and are your priority. But you also want to kind of strategize all the other people that sit in the other kind of buckets of kind of impact and influence, how you can kind of translate the value proposition into then ensuring that they're kind of a high priority, high influence, high interest stakeholder as well. And if you can kind of tap into what it means for them, what it will give them, what it does for them, both on a personal level, but also within the organization, within their department, that's sometimes how you can kind of get more people into that kind of priority, kind of high influence, high interest place. I don't know if you want to take 5-10 minutes now, just well, maybe 5 minutes, just even if just making a note of this matrix and kind of mapping out a few key players that you typically have in all of the deals. You know, a couple of our clients have 4 or 5 people that they know need to be in play and need to be engaged, and if we don't have one of them, we're going to end up in that cycle of not getting anywhere. So we you know, whether it's a clinical governance or a clinical sign off from an anaesthetic lead, or in the finance, there might be a business manager that needs to be involved from a budget sign-off perspective. It's those kind of people having flagged as, you know, if you've not got them involved, you need to have them involved. I don't know if anybody's got any thoughts or wants to jump in with the kind of key people that they have to have in every deal. I think, Sean, you mentioned obviously your engagement today, it's been quite wide in terms of those, but in terms of key stakeholders you've got, I'm presuming you've got kind of a short list of the key people that you need to have involved.
Yeah, we have basically what we call our critical success factors of what we need to tick off before we move forward with an account. So again, like you mentioned, the procurement, you normally have one person leading who wants to adopt it, and their team are normally on board with that. And then it's just, especially hospital wide, it's procurement, it's MBME, infection control, all the various things that we look to make sure is signed. And also one of the key bits for us is making sure we have a training champion within the hospital that want to take it and want to lead it, because we are a small team and we do a lot of the training of the high wards, but it's that thing that we always have this matrix that the hospitals work to, is that we have to train 82% of the staff. I don't know where that 82% comes from. We ask and it's always the same figure, but they don't know where that figure comes from. So before we can class it as being trained. So one of the things we do look for that's key is this training champion, because again, wards that don't really use NG tubes, they can forget simple, even though the product's dead simple, you just have to press one button. But anyway, they do forget. So it's making sure we have a leader in the hospital that's going to run, keep this pushing forward. And that's where our successes have been, is having that real champion of NG Pod to keep pushing, for it. And that's half the time that is the difficulty of changing that pilot to a commercial sale, and it's having that champion.
And I think, just to add to that, I think that's the point, isn't it, where you've got that list going into those discussions. We've had scenarios before where it's kind of like, asking the client or the potential customer, who is it that needs to be involved. Once you've got that exposure to who those people need to be, taking that off their hands and saying, look, we know that we need to be involved in the X, Y, and Z discussions with these departments. Are you able to put us in contact with those, and then kind of take it upon yourself to kind of start those engagements? If they're kind of comfortable with moving forward, it kind of helps try and drive it a little bit further, because I think we've all been in those situations where you've jumped on a call and you're supposed to be getting an update after a month and they've not had the conversation that we need to be had. And it's, if you've got that map of people and it's really clear where the value lies, and even that engagement that you have with them initially, if you're reaching out to them, mapping out what it means to them and what the savings could be. So it's going to procurement, we're working with X team, and this is what it means to them, and this is the kind of financial benefits. It's all about what does it mean to that person, and it tends to get them listening a little bit more. So it's really key to the whole process, I think, and not getting that stall or trying to. You'll always get a small stall, you will always get that stall, but it's how can you reduce that or minimize it?
It's normally not small.
Yeah, exactly. Trying to keep optimistic, but it is it's these challenges that you try and identify, like you say, early on, isn't it? And then try and kind of as best you can minimize. You will always get the challenge, but
I think also the other bit is just to add is that also when you're dealing with that champion, they also don't know who to include a lot of the time. So I think it's from our experience with doing different hospitals and things, you start to build what we consider our critical success factors. So we normally, when a new one comes in, we actually run through that, and then a lot of the time it's like, oh yeah, I didn't think of them, because that's where the real stall happens, is that they're really keen to move forward, and then all of a sudden someone comes out from another space and it sort of stops the whole thing. It all delays, or an evaluation needs to expand into two different areas, all this sort of stuff that starts to create these stall moments. So that's why we've kind of developed this list, and we run through that really, because also you start to see the level of commitment that they have, because a lot of them go, oh, that seems a lot of work, and that's when it starts to sort of wane a little bit, or you have the ones that go, yeah, that's fine, I'll get all these on board. So that being a small team, that's where we tend to now start to focus and try and move forward and put the resource where we know we're going to get that, i.e. hopefully in the end the best chance of a commercial sale.
Yeah, definitely. it completely makes sense. And I think just the slide here, and conscious that you're not going to be able to see the content of this, so I'm going to share the slides, but also I'll make this a bigger diagram as well. This is just kind of that thought process around that piece. I think you mentioned it, Sean, around how you can get other outside influences, whether that be at a national level, key opinion leaders, regulators and associations, other partners, organisations, even patient groups, to support the message that you're trying to convey and the value that your solution adds, as another form of like push into the organisations as to how you can kind of get engagement. So I've just wanted to include that because it's not potentially your direct kind of engagement or stakeholder, but they're definitely people that could help support kind of engagement for sure. And then conscious of time as well, so I'll just whip through these couple of slides before we get to something at the end. This just kind of was, I've included this to kind of articulate the difference between that pilot deal concept and then when you then start changing that into a like enterprise level deal, so you can see how the stakeholder piece changes, the various different organizations that then need to be involved, the kind of the more rigorous sign-off process that will be in place, the committees that you mentioned, Sean. There's probably one in each one of those organizations for each of the things that you need to get signed off. So it becomes a lot more challenging. And I think the key thing here is knowing what those are and who's involved and the key stakeholders at each stage to be able to tick off as though, right, we've ticked that box, we've had that conversation. You're kind of preempting the work that you'll need to do. And it's really key to make sure you've mapped that out across the stakeholder map. Just skip on through that slide. I think, Sean, you're potentially doing a concept of this already within your organisation. So a qualification framework that will support when you're engaging with stakeholders is really critical. So understanding, have they got the budget? Have they got the authority to kind of be the decision maker to kind of push this forward within a department? Is there a need or an urgent problem there? Sean, using you as the example again, in terms of that piece where there's been, you know, a never event that's occurred, it should hopefully be the driver to push them forward. Obviously, it shouldn't happen in the first place to start, but kind of referencing those types of things is something that kind of builds that need. And from a time frame perspective, so is there some funding that's available that allows them to access the solution, and time bound kind of constraints that you can kind of work with, that will mean that they can kind of push forward with the solution, and ultimately building a champion at the end of it. Sorry, I think there's just been a point on regulation. So do you mean regulation in terms of like medical device regulation?
Well, regulation, even getting like DPIAs and getting the IT department to evaluate you and so forth, right? There's all those hurdles that come in.
100%. And I think in order to get to the point of kind of the pilot discussion and embedding within an organization, there's the streams of, like you say, compliance and regulation around DTAC and the whole compliance and governance aspects and all of that kind of thing that need to be in place in order to kind of move forward through this process to actually get something across the line. You would be able to do some of this with regards to, like, for example, if you're not on a procurement framework and you're going for a small kind of pilot site scale project, then that won't stop you getting through the process. But things like IT governance and things like that need to be kind of signed off, because you'll go through the governance committee, and the sign off there that's required is you've completed a DPIA and there's all the relevant documentation. So there's some ways in which you can kind of get support on those elements around compliance. There's a couple of partner organisations that we've got at Coentry that I can kind of point you in the right direction of, if that'd help. And
that would be great. If you pass one DPIA, is it fair to assume that you might pass all the others or not?
I'd say that it depends on what the templates are that you've got. What we found with a lot of our clients, we've started to build up a pack of the kind of key information that we tend to need to submit through the process. So once you've done one, you can pretty much use that document next time. It just depends whether the trust have got their own templates that they require you to complete, and their kind of committee processes are all built around that. their internal document and the flow because it's built into their structure. But I'd say you would typically get you can use the same materials over and over again, just with some small tweaks, building that compliance pack up that you have.
Great, thank you.
Kevin?
Yeah, just to comment on that. So most trusts expect you to complete a DPIA on their format and their headed note paper, which is a real pain. And that's really what the passport is designed to overcome. There's not many differences. You can obviously recycle and reuse the material. Sometimes I'll put in a few slightly different questions or order them slightly differently. But really, once you have a DPIA, except the passport will be, once a DPIA is accepted, say the roll free is acceptable all over the country, in the same way that when we do research, once it's accepted for NIHR funding or as a portfolio, is then the same costings are accepted all over the country, whether they like it or not. So that's the situation.
Yeah, I think, Shane, it's that kind of point of you've done one for an organisation that's very similar to the organisation you're trying to work with, and that kind of gives them the confidence that you'll be able to get through the hoops, but you're going to have to do the DPIA from their format. They tend to be the same types of content, but yeah, as Kevin said, it has to be their document. Same with, typically business cases and the whole kind of return on investment metrics and how you can convey that financial benefit as well tends to have to be completed alongside it too. Moving on a little bit further then. So obviously we talked about kind of the champion, identifying the champions, pretty critical. So not every kind of sport is a champion. So you might have somebody that's, saying yes on the calls and all the rest of it. Sometimes you can kind of test the thought process behind whether they're a champion. So there's some kind of prompts in here as to kind of, making sure you're flagging the right people to be having your back through that process. And then ultimately this whole methodology is ultimately to try and speed up the sales cycle. Obviously we've got all the challenges that you have flagged and that you're kind of currently facing. Building out the value proposition is to build out the key elements that each of the stakeholders and the people that are involved in this process is really critical to them, for them to be able to sell through their kind of lines of reporting and sign off, etc. So it should all follow through. Just then basically towards the end, Shane, you mentioned about NHS compliance experience and evidence. So having kind of created sets of information and materials, so deep templated DPIAs that you kind of use and kind of lift and shift quite easily, evidence and case study packs and things that you can share after meetings is really critical as well, that's relevant to each of the groups of stakeholders. So if it's a compliance committee meeting that you've joined, having the relevant information that's relevant to them is key, and it all builds from that value proposition. What does it mean for me and why? And if you work from identifying each of those key groups and the value that it means for each of them, it can kind of all make the process a lot easier down the line, because you kind of get to the end, you think, oh my word, I've got all this stuff that I need to complete, but actually why am I completing it and for who? And it can be the guiding principle through some of that, and even a lot of your sales materials and how you're kind of starting to build out kind of pitch decks and your solution decks and stuff like that. And then just to finish up with 58, so I rattled through the last couple of slides and conscious that we covered a lot of ground, but any further questions, any thoughts, reflections? Hope it kind of give you a bit of an insight and helped a little bit in terms of some thought process around value prop and what it can mean, and probably gave you a lot more thinking to do, and hopefully it did so. But Shane, from your side?
Yeah, it's just a reflection. It seems like to get anything into the NHS, you really need NHS focused investors, right? Investors that get how long this system takes. Would you agree? And is there a way to figure out who these investors are?
I'd definitely say if that's the situation you're in, and because of the length of the sales cycles and the sign-off process, you do need to have somebody that's aware of that, because otherwise you'll end up sharpening your pencil, I suppose, in terms of what you're presenting to them in terms of kind of return and all the rest of it, and where the revenue flow will run. And you're only going to squeeze something and create more pressure yourself. There are specific investors that want to support the NHS-led technology. I'd say if you can find, from experience, if you can find an investor that knows the importance of getting the NHS evidence and is willing to back that side of things, it also can translate quite well into the private space as well. If your technology will help in that space, because it helps them it helps open doors in terms of mass adoption or like wide scale use within the NHS, gets people listening within the private space as well. That evidence is translatable that way.
Great, thank you.
Sure.
Yeah, I was just going to say, obviously, that is absolutely massively important that you have an investor that understands the NHS. Now, one of the things they do look at is the matrix that they use is the acquisition cost of a customer, and it's also versus the lifetime value of that customer. Now, what that means basically is that, i.e., how much does it cost to get you in there, and once you're in there, what is the lifetime value of that account? Now, one good thing about the NHS is once you're in, and it does take a lot to get you back out, or a significant development further to get you out. So that the lifetime value of the accounts of an NHS tends to be good, but the cost of acquisition is how long. So if I give you the example again of that Salford one that took 3 years, if it's about growth, isn't it? If every account takes 3 years, they're going to be very, they can't see the growth aspect, and your cost of acquisition versus lifetime value would be a very low score, and typically what they look for is 3 and above. If you just honestly to put it in Chat GPT, and it will give you a good matrix of how to work out those figures, and what they tend to look for is anything above a 3 when they start to go down the initial interest, all that sort of stuff, and then start to do the due diligence of can you achieve your growth figures, because it's all forecasts. Let's face it, forecasts are all made up. So it's about proving they have their matrix, how to discount it all and move it forward. But one of the things you need to look at is your cost of customer acquisition versus lifetime value. That's the key one they look at.
I'm conscious of time, and I know people have got other meetings. So unless there's any burning questions, I was going to bring this session to a close.
Thank you.
Yeah. So as I mentioned earlier, and Connor's mentioned, happy to have a one-to-one session to go through this in a bit more depth. Hopefully you found it all very useful, and it's probably part of the foundation that I would suggest that you need to get right in terms of accessing the NHS. Would like to thank Connor from Coentry for his time today, who's been the partner supporting us with the value proposition session. Any other questions, anything else, feel free to drop me an email. And thank you for today. Thanks for attendance and all your participation and engagement. Hope you found it very useful. Thank you, and see you on the next session, which I think is 2 weeks on Tuesday, not Wednesday. Phil, am I right in saying that?
Yep.
So see you then. Phil will send out a email after this session with the actual PowerPoint slides and an evaluation form. If you could complete that, I'd be most grateful. And if there's any other assistance you need, then we're around. So please get in touch, and look forward to continuing with this program.